Uh, the topic given to me is a drug fever. What should be the clinical approach? So this is not a, I'll say, a rare condition, though uncommon in practice. We tend to see it very often on. And I'm going to discuss this. Straight away, I start with the case, which I have seen very recently. Then we'll discuss. This is a child who's 3 years old male, fever for last 5 days, intermittent high-grade fever up to 105, and it started with 100, 101, and on day two it became 104, 105. Pain abdomen for last 2 days, intermittent and periumbilical, decreased oral intake, and uh, the child was taking ofloxacin and metronidazole from a private practitioner for 3 days and had received 1 dose of typhoid vaccine. So a clinical diagnosis was enteric fever. That's the commonest cause of fever. And ceftriaxone and supportive treatment was given in this scenario. So once we investigated, we found there's anemia. Then there is TLC is only 1400. There's platelets are 2.3, and there was a concern that possibly are we dealing with straight away HLH. So ferritin and triglycerides were done just to rule out HLH. LFT, KFT were normal, urine was okay. And after 24 hours, we came to know this most likely salmonella typhi. There were NLF growth. And after 48 hours, the child was found to be sensitive to ceftriaxone, and we continued with ceftriaxone. On day 3 of admission, just I think after maybe third day of admission, the child's worsened. Fever pattern remained as hectic as it was at home. The child was extremely became irritable in the morning, excessive crying, and the pain abdomen increased. The child over 3 years was just pointing towards the abdomen. Weak and rapid pulse, and he was tachypnic as well, shifted to the PICU. On examination, it was found that the abdominal fullness, rigidity, guarding, and the right iliac fossa was appearing quite tender. Ultrasound and CT were immediately done, and they confirmed that this is perforated appendix. If the child was operated, appendectomy was done with peritoneal toileting, and antibiotics in view of hemodynamic instability was upgraded to meropenem. Now, child gradually improved in ICU over a period of 72 hours, and he was shifted out to the room after 72 hours, and the child was given a treatment with meropenem for 7 days. And we planned the child to discharge on day 10. I was quite afebrile for last 3-4 days, active, accepting orally. And there was a discussion that we must complete 14 days of enteric treatment because otherwise the chances of relapse are higher. But the father on the same day evening talked to one of the unit consultant. He said the child is still having, now child started having fever after 4 or 5 days, is 101. The consultant advised continue same. Fever increased over next 3 days, 102, 103, and there were 3 spikes a day, no shivering. So we readmitted the patient on day 14. So we are counting the day from day 0 as a date of admission. Okay, no thrombophlebitis, no cough, cold, no urinary complaints, abdomen is soft, no pain abdomen, vitals are stable, and we sent the investigations. So what was in our mind? We thought most possibly some collection left inside because of peritonitis, maybe some intra-abdominal abscess, or is it a hospital-acquired infection the child has picked up during the stay? And the third discussion in the unit was, most possibly we are given lesser days of management of peritonitis, even if the recent data tells 5 to 7 days after source control is sufficient. They said possibly it was inadequate. We restarted this after sending blood and urine culture and other investigations. Other possibility was, is it a drug fever? We are giving beta-lactam antibiotics. First we gave cephalosporins for 3 days. And after 3 days, we changed over to meropenem, which we gave for 7 days. So is it a drug fever? And that was one of the possibility. With these possibilities, we kept the patient for observation, and these were the investigations. Hemoglobin 8.7, counts look okay. and then platelets are quite okay. CRP is normal, urine routine is okay, ultrasound was normal. We observed the patient for next 48 hours in the hospital. The fever pattern continued same as at home. So the fever was going on similarly for almost 5 to 6 days, 3 spikes a day, and the fever was going up to 100, 200, 3, and there was no shivering. The child was not sick, he was active, accepting orally. Even during the fever, the child was not looking very unwell. So we reinvestigated after 48 hours of admission, reinvestigated. Again, we found count, CRP, PCT, urine, routine, culture, blood culture, everything came normal. So we thought of possibility of drug fever was considered. We stopped meropenem. Child became afebrile after 72 hours, and then the patient was discharged in good general condition. So this is a story which is fitting into drug fever. And the drug fever is a disorder which is characterized by fever that occurs with the administration of drug and disappears after discontinuation of the drug. It is also defined as febrile response to a drug without much cutaneous manifestations. It's not something like dress and all that. So what are the mechanisms of drug fever? Most likely it is a hypersensitivity reaction to the drugs like carbamazepine, phenytoin, abacavir. These are the classical drugs which lead to hypersensitivity reactions. Or it could be idiosyncratic reaction like a malignant hyperthermia with a muscle depolarizing drugs, something like succinylcholine. Reactions may be due to direct pharmacological action of the drug, like killing the bacteria and releasing a lot of toxins. And this can be similar to Jarrick's hexamer reaction. Or this is an altered thermoregulatory mechanism which happens with atropine being an anticholinergic drug, or amphetamine or cocaine, which are sympathomimetic drugs. Now, to what should be the clinical approach? We have to evaluate for other causes of fever. Short duration usually not associated with drug fever. Most cases of drug fever occur after first few weeks of drug administration. Drug fever is generally a diagnosis of exclusion. So the clinical approach will be, first step will be to rule out other causes of fever. And the concept is no harm to the patient. If you're very sure that this is most likely to be drug fever, only then go ahead. Now, if we take the causes of fever after 7 days, there can be infection, rheumatological diseases, neoplastic disorder you heard in the last discussion. And these are the causes of fever more than 1 week. And if you say drug fever, in one of the study, it is contributes just less than 1.5% of the cases. So these are the common cases which can happen after one fever, after more than 1 week of duration. Now, if you take the general appearance of the patient, generally the patient appears okay, feels well. But there have been cases reported where the patient is sick and ill appearing. So you cannot rule out that possibility, but mostly the patient appears okay. Relative bradycardia, I think more recorded in adult patients and lesser in the pediatric patients. The timing of fever. Now there is a highly variable lag time between initiation of drug and the onset of fever. It can be sometimes few hours to few months. The median reported time is something like 8 days after starting the medication. Most cases tend to occur after first few weeks of drug administration. Cases have been reported where people have used drugs for months of several months, and then the drug fever comes. What is the pattern of fever? There's no pattern of fever which is specific to drug. For example, in our case, it was an intermittent high-grade fever. The fever pattern, the severity of temperature, they are very variable in drug fever. It can be low grade, it could be high grade, it could be half temperature, it could be remitting fever, it could be intermittent. All patterns have been reported with drug fever. So you can't say this type pattern of fever should fit into drug fever. If you take skin rashes, something like 18 to 30% of the patients may have associated drug fever. They may have rashes, skin rashes, but the absence of rash definitely doesn't rule out the diagnosis of drug fever, because the rash only occurs in 18 to 30%. The type of rash varies. Even the rash is not very specific. You may have just erythema, morbilliform eruptions, urticaria. It could be rash with lymphadenopathy, and sometimes they can be some serious cutaneous reactions, exfoliatives, something like erythema multiforme, Steven-Johnson syndrome, toxic epidermal lysis, toxic epidermal necrolysis. All these things of rash have been reported. What are the underlying conditions in pediatrics where we are likely to see a drug fever? It is HIV and cystic fibrosis. And in adults, malignancy, liver, and renal impairment, a lot of drug fevers are reported. Now, investigations against are not very useful. The TLC is elevated in 20% of the cases with eosinophilia. CRPS are again not particularly useful. Neutropenia, agranulocytosis is reported with drug fever associated with penicillin and cephalosporins. Disturbance of liver function may be there. And creatine kinase and myeloglobinuria could be there in a case of neuroleptic malignant syndrome. So all these investigations may be abnormal. So then what is the clue? Like back to our case, I think it was an easier case if you see the literature. General appearance of the patient was well. There was no bradycardia. The fever pattern was intermittent high grade. There was no rash. Timing of fever, received 11 days of beta-lactam antibiotics and then started having fever. Investigations, luckily there was no focus on infection. There was no abnormality, made my job much easier. And we ruled out other probable causes of fever. And after that, we discontinued the most likely offending drug. Now, before we take away this offending drug, we must review the medication history and drugs that are more frequently associated with drug fever. I think it's very important, particularly in a patient who has got some comorbidities and being treated with several drugs. There it becomes very, very challenging and very, very important. If we see the list of drugs, just to summarize, anticonvulsants, which I named earlier, carbamazepine, phenytoin, phenobarbital, primidone, the reaction is supposed to occur to the tune of 1 reaction per 5,000 treated patients. Antimicrobials, the most notorious are beta-lactam and sulfonamides. Minocycline is also reported in nitrofurantoin. And if you take other idiosyncratic reactions where lead to very high-grade fever, sudden onset, malignant hyperthermia is because of succinylcholine, which is a muscle depolarizing agent. Inhaled anesthetic agent like halothane can lead to malignant hyperthermia. If you take serotonin syndrome, dextromethorphan and tramadol, which are the drugs which are used in pediatrics, may cause high-grade fever because of drug. Hemolysis can lead to G6PD deficiency, and we know what are the drugs which can lead to that: pimacine, quinine, sulfonamide, and nitrofurantoin. They can lead to hemolysis and release of endogenous pyrogens. Now, fever can be just an extension of pharmacological effect of the drug, like chemotherapy, leading to cell necrosis, lysis, after leading to fever after 4 days of chemotherapy. Similarly, in syphilis, this is Jarix eczema reaction occurring after killing of bacteria in secondary and tertiary syphilis. So then the drugs can lead to they alter the thermoregulatory mechanisms and lead to fever, like exogenous thyroid hormones, L-toxin. Drugs with anticholinergic activity like atropine, antihistaminics, phenothiazine, sympathomimetic drugs like amphetamine and cocaine, and some drugs like amphotericin and bleomycin also have an intrinsic property of causing pyrogenic reaction and fever. No drug cessation to establish the diagnosis. If we discontinue all drugs in a patient who is receiving a lot of drugs and we have a question mark which particular drug is causing this drug fever, then we can put the patient at risk. So in that situation, I think due diligence should be paid to find out which is the most likely drug. And it's a good idea not to stop all medication, but one by one, which can be the offending drugs with the list I've given you. So care should be taken that not to put the patient at a risk of greater harm. And I tell you, this is not an easy decision. Even in my simpler case, it is not an easy decision in clinical practice. You always worry the patient should not worsen. Okay. And offending drug cessation to establish the diagnosis, I think the result comes after 48 to 96 hours of discontinuing the offending drug. In our case, they came just before, I think, 72 hours. In case of suspected antimicrobial induced drug fever, in this case, in our case, it was easier because we have completed 14 days of drug therapy. And suppose, for example, the fever is coming after day 7 or day 8. in that situation, what could I have done in case of enteric fever? Possibly, I could have gone to maybe another class of drug, that is azithromycin. Now, confirmation of diagnosis with re-challenge. This is very controversial, should be performed with extreme caution. Now, this child is sensitive to or a hypersensitive to beta-lactam. And in future, this child is just 3-year-old. He may need these beta-lactam in future. And we'll closely watch what happens to this patient, but the literature is sort of silent regarding the reuse of drugs. What is holds for the future? In the future, there's going to be a personalized medicine because role of pharmacogenetics is coming in a big way to find out which are the drugs which can lead to adverse drug reaction to a particular individual. Now, give you an example. Hypersensitivity is the most common cause of drug fever. Genetic predispositions to drug sensitivities have been described. Now, drugs which can have a drug genetic predisposition have been described as abacavir, your carbamazepine, allopurinol. Now, abacavir induced hypersensitivity reaction, but it's an antiretroviral drug. We know that this is associated with HLA-B5701. So if you test for this allele, the clinician can know who are the patients who are likely to get hypersensitivity reaction to abacavir, and you avoid this drug in that particular patient. So this is something like which is going to happen in the future. With these words, I say thank you very much for your attention.